Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
Well, I am back from a much-needed vacation. It was great to get away and spend a week with the family, and it was great to be in some nice weather, but just as great as it was to get away, it is great to be back. I was on a cruise ship with my wife and kids, my in-laws, my parents, and my wife's sundowning 95-year-old grandmother. As the old saying goes, I need a vacation from my vacation. I'm working on getting back to DMs now that I'm back. I was largely off of the DMs because I really did need to detach. I needed a break, but I am back. I'm catching up. I got off the ship yesterday. I got home. I did a couple things, took a nap, and then I went right back to work. Night shift. We were busy last night, so I am working on it. I did, though, keep up with my Patreon DMs because I feel I owe that to the people who generously support the podcast. And please consider doing so if you don't already. It really helps me out because doing this content and the research and writing and content creation, it is a lot of work. You've heard me say it's like an unpaid extra full-time job. Patreon support is $3 a month. Very cheap. The link is in my bio on Instagram to sign up. I'm not in love with being this way, but the DMs on Instagram have gotten to be so much that Patreon subscribers get priority through the DM feature in the Patreon app. A sincere thank you goes out to those who have signed up to support the podcast. Also, a couple quick other business things. I rocked my Frontline Optics sunglasses while on the cruise. Use code OKMedic at checkout for a discount. And I also have a new agreement with X Shears. See these beautiful shears? The YouTube people can see them. I love these things, and I'm not just saying that. I really do use them, and I have for a couple of years now. I am thrilled that they wanted to be an affiliate and be part of the podcast. Just like Frontline Optics, the discount code is keeping things consistent. Okay, Medic. All right, let's get to the podcast content. As far as trauma, this is Trauma Ramblings, and we are covering two topics today. One is decompression of tension pneumos, and the other topic that I'm going to talk about is that study that came out that showed that when it comes to trauma patients treated by ALS versus BLS had significantly less mortality. But first, let's talk about decompressing tension pneumos because we as paramedics keep fucking up needle decompressions. I'm sure that this will transgress into some rantings and ravings, and I will make some incendiary comments about how I feel that Helen Keller would be more accurate than paramedics at finding landmarks. But as always, keyboard warriors, be informed that while I do take opportunities to point fingers and call out others, I will never not be honest and open about when I have screwed something up. If you listen to the podcast regularly, you know that a large percentage of the case studies and learning points I do come from cases that I have had where I've learned something new, or I've done something that I didn't feel was up to what I would consider to be my own standard, or something that I straight up screwed up. To err is too human. It is just a fact. And that does not absolve us from putting needles in left ventricles, things like that. But I do want to be honest with everybody that I have screwed up a needle decompression. I didn't put it in the heart, thank God. But it was years ago when they first rolled out the lateral approach where I was working. And I had a patient that I suspected had a tension pneumo. I heroically opened up the needle decompression kit. I thought I found the landmarks. I stabbed the patient with a 14-gauge catheter, and I successfully performed a hollow needle biopsy of the patient's liver. Now, thankfully, I was able to get follow-up. Well, thankfully for the patient. Kind of backwards the way I worded that. I was able to get follow-up and confirm that, thankfully, the patient did absolutely just fine. The follow-up note told that the surgical resident simply pulled out the catheter, held finger pressure on the site for a couple minutes, and the patient was fine. Nevertheless, that doesn't mean it's okay. I fucked it up. So right there, that's a real-world example of how this happens. I think that it is important for all of us, and most especially educators and content creators to be very honest about things that we have screwed up, because nobody is perfect. It's one of the reasons I started the podcast. Years ago, I was listening to these various podcasts, and I kind of felt like some of these people were putting themselves on a pedestal, and everything was a perfectly executed scenario that they would talk about. And I was like, that's not how the real world is. I think we need to be honest, because again, to err is to be human. I thought it was this one particular surgeon that I follow on social media, but I went back through his stuff and I couldn't find the post. So I don't want to misquote or misattribute credit. Whoever it was, kudos to you. But someone, I think it was a surgeon, put out a post a couple of years ago that I thought was really admirable and necessary. And while this physician challenged us to do better, be better, and learn from our mistakes, he said that we need to be open and honest about our screw-ups. And to be a leader and an example, he or she posted a list of things that they have screwed up, which I thought, again, quite admirable. That being said, it's not okay how often and how badly we paramedics are screwing up needle decompressions. Just last month, I heard yet another, and this is just me being told secondhand by somebody, and not reading accounts online. This is one paramedic I know to me telling me about a call that I actually heard dispatched, telling me another account of a paramedic putting a 14 gauge needle into somebody's heart. Last year, the University of Virginia presented overutilization of EMS needle decompression, and they presented about, quote, incorrect assessment, improper location, and unneeded needle decompression. They gave 2 cases of patient harm. It is open access. URL is in the show notes. Check it out. Oddly enough, the link wasn't working for some people. And I was like, why is it not working for some and it works for everyone else? And the common denominator was it wasn't working for Canadians. Very odd. I don't know why that is. Maybe it's an effect of the trade war, but the URL works in the United States. I could go on and on and on with stories of bad needle decompressions, but you get the point. We are not doing a good job finding the landmarks, and then we stab people in those incorrect areas of the body, and that is a big problem. I think that the root cause of this problem is poor training on the part of EMS education. Now, that is a duh statement. That's low-hanging fruit to go at, but I don't think that they do a good job teaching how to find landmarks in paramedic school or in continuing education. You have to use the sternum as your guide and find the sternal angle or ridge to find that second intercostal space if you are using the anterior approach. Now, some say that there is less potential for error using the lateral approach, but as you heard from my personal experience, I can tell you that you can muck that up too. If I were a betting man, I'd say that it is probably mucked up just as often as the anterior approach. Granted, I don't have stats right in front of me. That is just my speculation. Nevertheless, in my opinion, EMS education does a shit job of teaching how to find landmarks. You have to memorize second intercostal space, mid-clavicular line, or for the lateral approach, fourth or fifth intercostal space, anterior axillary line. That's all well and good for passing a test, but when you have a lady like I had last year, who was 350 pounds laying flat on a stretcher with 2 stab wounds in her chest, and I'm not trying to sound overly crude, but she's supine on the stretcher with her absolutely massive quadruple M breasts lying like 2 massive jello molds over top of her torso, memorizing second intercostal space, midclavicular, fourth to fifth intercostal, anterior axillary doesn't really help in that situation. How the hell is the rote memorization of that landmark going to help you to find the right spot to put the needle? You need to know the structures of the chest, the sternum, the ribs, the clavicle, and how to palpate and map it out. And that lady, I was able to palpate and map it out and successfully performed a needle decompression. She woke up. Go figure. The Narcan that the ground crew gave did not wake her up, but another story for another day. Kudos to my friend Dr. Jose Torres. If you follow him on Instagram, he's the sangria-loving airway doc. I was going to do a video on how to find the landmarks, but I'm shooting the breeze with him over text one night, I was like, hey, why don't you do a video on this? I bet you could knock it out of the park. And he delivered. He went to a cadaver lab and he did a video for us. He posted it on his Instagram on March 7th. So go check that out. Thanks, Doc. But we are inadequately trained. You don't believe me? Show of hands here. Who has gone to a yearly skills review, gone to the needle decompression station, and you have the same mannequin torso that gets decompressed every year, and there's 5,000 holes in the correct-ish spot to put the needle in because it's been poked by every paramedic in the department numerous times over the last couple of decades. But we fuck these things up far too commonly. Now, I do not usually take the large urban area medical director, gathering of eagles approach of EMS screwed this up, let's take away their ability to do the skill. I think that is haphazard and it's usually very flawed. Like the projects that took away intubation for paramedics, or they greatly limited paramedics' ability to intubate. I think that those projects relied on stats and air quotes, academic literature that was flawed, biased. And as I have said repeatedly, if you truly tracked ED physician tubes as closely as paramedic tubes and tracked the numbers, the success rates, and the complications, I think that everyone would be wide-eyed. And my speculation / hypothesis is that the ED physician stats would largely mirror EMS stats. So I don't really buy in to the whole pulling the ability to use a tool because some paramedics have screwed it up. I think that's cop-out medical direction. But I don't think we should be doing needle decompressions anymore. And I don't think we should be doing them because there is a better option, a safer option. You can't just take away the ability to decompress a chest and not offer an alternative. People die very quickly from tension pneumothoraces. Decompressing a crashing tension pneumo is not one of those resuscitate before you do it things, or, well, let's just get them to the ED and they can do it there. No, if you do not immediately decompress a true tension pneumothorax right then and there, that patient will very soon be in a state of traumatic arrest and then die. The better alternative, in my opinion, is finger thoracostomy. Now, disclaimer, I have never done one. It's not in my scope. It's not in my protocol set yet. I hear it might be coming. I hope it's coming. But I am not going to be a charlatan and tell you all about how easy the procedure is or how to do it or what you'll experience when you do it because I've never done one. And we don't practice charlatanism on this podcast. Maybe sometime I'll do some content with someone who has done a lot of fingers. That being said, reading about it, watching videos, and talking to a trauma fellow about it, and talking to paramedics who have done it, it seems to be a very simple procedure. They all say that it is really not that hard, and arguably, it's safer than a needle decompression. You're kidding. What? You're taking a scalpel, it's more surgical? Well, think about it. Finger thoracostomy, you're using a small scalpel, a Kelly clamp, and a finger. Yes, it is more dramatic. I'll give you that. There are more steps. Yes, you can lacerate stuff with a scalpel. You can do some damage with a Kelly clamp if you don't know what you're doing. But consider the argument that in needle decompression, you're putting a 3, and that is at an absolute bare minimum. It really should be much longer than that. So an 8 centimeter or a 10 centimeter, 14 gauge or 12 or 10 needle into a chest. That is a friggin' spear. With finger thoracostomy, you're putting your finger in their chest. Now, some people, experts, not just me, provide a really cogent argument that this is much safer than the metal pointed blade spear. And I think they have a really good point. So I am taking the stand now that it is the official opinion of the World's Okayest Medic podcast that EMS should abandon needle thoracostomy and adopt finger thoracostomy. I reference the Taming the Shrew and the SRU and the Life in the Fast Lane blogs here. With finger thoracostomy, you guarantee that you actually make entry into the thorax. You can actually see and feel the lung re-expand. That's a hell of a lot better than blind insertion of a needle, in my opinion. Like, well, I can't palpate shit, but it looks about here. Yeah, stab there. Oops. The finger has a low rate of complications. Granted, there are no studies currently, not that I could find, send them if you know of any, that randomized or even observationally or retrospectively compared needle to finger, but the rate of finger thoracostomy complications is documented to be low. One study of Australian HEMS providers, 103 patients who had a finger thoracostomy performed. Of patients who were in traumatic arrest, there was a 16% ROSC. That's big numbers in trauma ROSC. And there was a long-term complication rate of 4.8%. Predominantly infection. 2 patients did have complications directly related to fucking up the procedure. One was an arterial bleed, oops, and one had lacerations to the liver and diaphragm. Oops. Those are not good. I'm not saying they're okay. I'm not poo-pooing them. And I could see some anti-finger medical director or administrator waving that around. But consider, according to a study in the Canadian Journal of Surgery, as always, references provided in the show notes, that in residents placing chest tubes in this study, there was up to a 30% rate of complications. 35% of that 30% were insertion problems. And of those, 53% were malpositioned and 12% were infectious. This aligns with the conversation I had with a physician friend of mine. We're just shooting the breeze and he's spilling the tea to me about a hospital morbidity and mortality meeting where they're reviewing a case about an EMS needle decompression that was successful, but unfortunately caused a minor lung laceration. He said that this one ER physician who is a medical director of an EMS service was banging his fist on the desk and making a much bigger deal than what this particular trauma doc felt was necessary about this crew and how they performed. And this trauma doc shut the ER doc down, the ER doc who's also a medical director. The trauma doc shut him down and said, hey, by the way, while we're on this topic, can we discuss the messed up chest tubes that we receive in the unit from the ED? Zing. All right, that's what I have to say about finger thoracostomy versus needle decompression. Let me move to the paper that everyone in the EMS social media sphere seems to be talking about. And this is from the March edition of the Journal of Trauma and Acute Care Surgery. And it is yet another overly large mouthful of a title. Emergency medical services level of training is associated with mortality in trauma patients. A combined pre-hospital and in-hospital database analysis. Why is everyone talking about this paper? Because the authors of the study concluded that trauma patients attended to by ALS providers versus BLS providers had less mortality. Now, this paper is open access. You can't access the open access link off of PubMed, but you can find it using a 5-second Google search. That is often the case with papers. I'll find a paper in abstract on PubMed. I won't be able to get the full text, and then I will plug in the title of the paper into Google, and voila, there it is. As I always say about articles and papers that I discuss on the podcast, do not just take for granted or law what I say. Confirm for yourself. Formulate your own opinions. This podcast is just my commentary. You don't have to agree with everything I say. What you are getting here are my thoughts on the paper. At first glance, reading the conclusion of this paper, I was like, hell yeah. ALS often gets the shaft in scholarly publications, in my opinion, because in existing academia, there has not really been any major mortality benefit shown when ALS tends to the patient over BLS. And in critical patients, it's sometimes the opposite. For example, a 2021 paper in the American Journal of Surgery showed that mortality was, quote, grossly increased when ALS attended to the patient versus BLS. Does that mean that ALS is so counterproductive that it harms patients? No. You can deep dive into that paper on your own, but I bring this up to illustrate the point that you could pull together a bunch of papers on ALS response and extrapolate and formulate what I think is a flawed and very superficial, I read the abstract only, based conclusion that when it comes to trauma, ALS does not help or even worsens outcomes. In my opinion, Medical academia kind of screws the pooch on research in general in emergency medicine, trauma, critical care, and pre-hospital medicine. Why? Well, what do they often look at as the primary outcome? And by often, I mean over and over and over and over again. They look at mortality. Why do they do that? Well, if you think about it, mortality is the ultimate outcome, but it's also a very easy outcome to study. It's objective. There's no gray area. It's the ultimate black and white. Did people live or die? Paramedics provided X intervention. Did they live or did they die? Or we tried A versus B in the ICU. Who died less? Easy peasy. Studying mortality as an outcome is indeed very important. I'm not saying that it's not. And our goal is to save lives. Does what we do contribute to saving lives, or does it have no effect? Does it waste time? Does it take time and effort away from other more meaningful interventions? Did it make things worse? We must study mortality. But while studying mortality makes for a good published paper, it leaves a lot out. What studies often leave out is morbidity, which means of and relating to illness. And ALS certainly reduces morbidity. Let's talk about morbidity and trauma, since this is trauma ramblings. If your grandmother falls and she fractures her hip, is ALS versus BLS attendance going to have any bearing on whether she lives or dies? No. However, morbidity is most certainly better with ALS. I would much rather her be given pain management and be more comfortable on the transport. It is far more barbaric to just pick her up, plop her on the stretcher, and give her a glorified Uber ride to the hospital. We can treat pain, and I'm not saying BLS is a glorified Uber ride. Just chill. You know what I mean. It's hyperbole. But getting back to it, we can treat pain, and I maintain that pain management is legitimate usage of ALS, and that helps grandma, reduces morbidity. Let's take it up a notch. If you're in a car accident and you have a traumatic brain injury and you also have a liver laceration, you're 30 minutes from a trauma center, you're hypotensive, which is a very bad thing for a traumatic brain injury. Did you know that in the setting of traumatic brain injury, even one episode of hypotension doubles mortality? That is a fact. So let's say BLS gets there, they put you on the stretcher, they haul ass to the trauma center, they save your life at the trauma center. You don't die. Score one for good mortality. You did, though, indeed, suffer a terrible brain injury that was massively complicated by hypotension. So, yeah, you didn't die, but now your wattage output is much dimmer than it would have been had that hypoxia and hypotension been corrected at the point of injury. You're no longer going to have that good job, the hot girlfriend, and you're going to need help doing daily activities like making breakfast and brushing your teeth. There's a good chance that the effect of that head injury could have been mitigated by good pre-hospital resuscitation at the point of injury. Maybe if an ALS crew got there and gave you some blood and got that brain perfused, or hell, not that we love crystalloid and trauma, but in traumatic brain injury, you don't want hypotension. So maybe even some normal saline or LR to get that blood pressure up and raise that cerebral perfusion pressure, your morbidity would have certainly been better. But you didn't die. I could go on and on and on about how paramedics fix morbidity and trauma, and certainly in medical scenarios. What we do as ALS, I truly believe in. To use a quote that the young people use, and Nelly, a follower, wrote this in a DM, that it slaps, whatever that means. ALS care slaps, to use a young person term. We definitely help morbidity in many respects, and we definitely sometimes help with mortality. But anyway, I'm rambling. Focusing on mortality is important, but it ain't the end-all be-all of outcomes to study. So let's get back to the paper. This was a retrospective secondary analysis of ESO data consisting of over 2,000 EMS agencies and 472,572 patient encounters from 2018 to 22. So that's certainly a good N number, population number. After filtering out duplicates, incomplete info, not applicable patients, and all that stuff that you must do when conducting a study, They narrowed that down to 32,493 patients. 30,735 of them were attended to by ALS, running the call either as ALS only or ALS assisting BLS. Regardless, it was ALS in charge in the vast majority of patients, and only 1,758 where it was BLS only. Right there, major problem. That is a huge disparity. That's 28,977 more ALS patients in a total study population of around 32,500. And that arguably skews the results in ALS's favor. Yes, you can do all that statistical procedure to make the data sets more equal, which you must do and is critical to do. But as you know, those tests are not perfect. And as any 11th grader learns in stat class in high school, the greater the disparity in populations, the less reliable the statistical methodology is going to be. So, as you know, they found significant mortality reduction with ALS versus BLS. And I thought, as I'm sure many of you did, well, duh, ALS can do life-saving interventions. Not the case in this study. I was kind of surprised by this. In this study, few patients had major interventions performed by ALS. 0.2% had an advanced airway placed, 0.7% had a needle decompression performed, 1.4% had an IO placed. This tells me at face value that a lot of these patients, and probably the majority of patients, were at low acuity, or even if they were higher acuity, very stable. So as far as outcomes, of patients treated by ALS, 1% died in the ED compared to patients tended to by BLS where 0.8% died. And that is less death for patients transported by BLS. What the hell? I thought ALS patients had better mortality. Well, going more downstream, looking at in-hospital and overall mortality, ALS did have less mortality. It was not a huge difference. You ready for this? 2.8% overall mortality with BLS. ALS was better at 2.7%. But those are raw numbers. As easy and low-hanging fruit as it is to just go by raw numbers, you can't rely on that. You have to do a statistical analysis. They used what is called propensity matching analysis, where the stats nerds match similar patients to reduce confounders, and they reduce bias, and they create conditions that kind of, sort of, but not really, they say does in a way mimic a randomized control trial. And with that propensity matching analysis, they found less mortality with ALS. In patients older than 50 years, ALS had 1.8% less mortality. In patients with falls, ALS had whoppingly, and I say that sarcastically, ALS had whoppingly better rates of not dying at 0.32%. Non-fall trauma was more significant, 1.29% better mortality with ALS. And when EMS patient contact times were greater than 30 minutes, ALS mortality was 0.63% compared to 2.11% for BLS. And that all translated to a 1.13 absolute mortality reduction with ALS over BLS. And after a bunch of statistical manipulation, that somehow resulted in a 60% relative reduction in mortality when ALS attends to the patient over BLS. Me too. I was confused by that huge jump. But as I said, the paper is open access. Go read it. But let's talk about the 1.13% absolute mortality reduction. Not necessarily setting the world on fire. I don't think that slaps. Now, I would love to do a 1 and 30-second reel where I say, 60% relative mortality reduction with ALS over BLS. But I don't think that would necessarily be transparent nor accurate. Not only does it not reflect what other studies have shown, not that that is perfect, but the numbers in the study they weren't terrible, but they were, Remember the p-value. That pain in the ass from stats class. That's what the P stands for, if you didn't know, pain in the ass. To be considered statistically significant, p-value should be low. less than 0.05. The higher the p-value, the more likely the results are due to chance, a coin flip, if you will. The lower the p-value, the more likely the results are, well, legit results. So for the age greater than 50 and the non-fall trauma, the p-values were less than 0.05. Age greater than 50 was 0.046 and non-falls was 0.047. Yes, that is statistically significant. Almost right there, just at the brink, but nonetheless statistically significant. The category EMS time greater than 30 minutes was close to significant, but not enough. Just over at 0.065. Falls, the numbers were not good. The p-value there was 0.7, which is high as it is pretty damn close to 1. So what does this tell me? Now, remember, I did go to grad school and I completed a graduate level stat class and 2 research methods classes. But full disclaimer, I'm not an academic. I'm not a statistician. I'm not an EMS professor. You won't find that in my EMS bio. What this tells me, though, is that as far as statistical significance, of the 4 categories, 2 were statistically significant, but just there, 1 was not statistically significant, and 1 just missed it. Therefore, my non-academic analysis is that this study is meh and doesn't really tell us anything useful. However, I'm not going to go deep into the rabbit hole here, but there is a cogent argument out there in medical academia that people rely too heavily on p-values. I came across a tweet by M. Celia Antonini, who goes by the handle @FoamECMO on X. She's a perfusionist and PhD candidate who is active in the cardiovascular foam ed world, and she wrote, "Death by p-value, 5 critical care interventions which demonstrated meaningful treatment effects, high posterior probabilities of real benefit, yet missed conventional statistical significance." And then she provides a list of them. She followed that up with, "Rigidly solely over-relying on p-value thresholds may obscure beneficial findings, leading to underestimation of therapies that hold substantial promise in critical care." She went on a little more. She dropped some freestyle statisticalese and then provided an article from a recent article in the Journal of Critical Care shared by Patel and Adam Green called "Death by P-Value, the Over-Reliance on P-Values in Critical Care Research." I will post a citation for the paper in the show notes so you can drop what you are doing and run to your iPad and read it. I'm not going to nerd out anymore because I've yammered long enough. I am also not going to wrap this all up in a nice conclusion. I included this stuff about the p-value because I invoked p-values while talking about the ALS versus BLS paper. And while I was writing this episode, I came across this tweet and figured, hey, this is good a place as any to talk about this. So read the papers when you have time, consider the p-value stuff, decide whether or not you think that paper had, well, any oomph. I don't think it did. And that's the podcast for today. It is lovely to be back. Thanks for tuning in. More to follow.